Yeah.
So we actually take call from home, which is really cool and almost unheard
Okay.
of in the peds world. We also are kind of a growing community hospital, so the ER isn't always staffed with pediatricians,
Mm,
so we do get
yep.
called in a lot.
I mean, people like me are staffing your
Yeah,
EPDR. Yeah,
yeah.
like
And
this
you guys
fucking
do
guy calling
great.
me.
You do
Oh yeah, I'm
great.
sure we
But
do.
it's like
Yeah.
always at 3 a.m. that you're like, I'm not sure.
That's the witching hour.
Yeah.
And it's funny because I guarantee you that patient came in at like 1 a.m. The doc probably saw them. They're like, all right, it's whatever, I can do this. And then 2 hours later, they're like,
Yeah.
shit, I
Right. They're like, I don't
can't.
know. I don't know. Can you just like be sure they're okay?
Yeah. Like,
And
look
it's
at this child. Yeah. Hello, everyone, and welcome to the next episode of the JAFERD cast. I am your host, Dr. Mark Pappadakis. No one particularly special, just another fucking ER doctor. So today we're going to be having Dr. Maggie Gaughran here. She's a world famous pediatrician. I say world famous because I know her. And I went to medical school with her. She was one of my former classmates, a year behind me. And I'm lucky to have her here with me to discuss. We're going to be discussing pediatric fevers and largely other pediatric based things, but mostly pediatric fevers. That's been a topic in my ER discussion for some time now, especially with the recent cold and flu season ending. For us, at least, it was pretty bad. So let's get her in here. I'm here at Dr. Maggie Gaughran. Hi.
hi.
So, Maggie, tell us a little bit about yourself. Obviously, I told people already, you and I went to medical school together, but just kind of talk about that, residency, any, training, et cetera, please.
Sure. Yes. So we were Toro Harlem. You were a year ahead of me, so I graduated when 2017.
2017. Yeah, I was 2016. Yeah,
Yeah, yeah.
2017. It's been a long, long
It
few
feels
years.
like so much longer. And I went into residency in pediatrics. I did my residency out at Good Samaritan Hospital out in Long Island, New York.
Ah, I didn't know that.
Yeah,
Very
yeah.
nice.
So,
Because we were at NIAC together. We did our
yes.
30 rotations each
Yep.
at NIAC. And that was, I had a lot of fun. I know you did as
Yeah, they were
well.
good. Yeah.
But so you were in Long Island, and then what about post residency? Did you know you wanted to do? Did you want to do anything particularly special? Did you want to specialize in anything, or were you just
Yeah.
like, I've always wanted to just be a pediatrician?
So I knew 100% that I did not want to deal with adults.
I
So
don't blame you.
yeah,
Adults curse back, and they're not as
they
cute.
do,
That's
they
makes sense.
do. Yeah. So I was an EMT for 6 years before I went to med school.
Okay.
And so I did the adult thing mostly then, and I was like, no, that's not for me.
And you got your taste of emergency medicine during
I
that as
did,
well.
yeah. So I thought of it. I thought of doing fellowship. So in pediatrics, all fellowships are 3 years, which is frustrating.
Okay.
So our residency is 3 years, and then a fellowship is 3 years. A lot of times in adult medicine, as you know, it's 1 year or 2 years, but for
Hmm.
some reason in pediatrics, we don't have that. So
We do have pediatric, and I know
yes,
it's you
which
can do either one. So if you
you
decide
do
to do emergency
four,
medicine,
right,
you would do an emergency medicine fellowship for 3 years.
in
How
three
does how would
years. So
that
I'd have
in three
six
years?
total.
Okay,
So I
and it's
do,
funny because most standard residency programs in emergency medicine are 3 years,
right.
or maybe four, depending on the place. So
Right,
that's
right. Yeah. So it
interesting.
always ends up being a little longer than some other fields. So I had thought about doing, PEM fellowship, but I had signed up for the National Health Service Corps while we were at Toro. So if people don't know what that is, they offer you, here's some money to put towards your loans,
Hmm.
which I had a lot of. I still have a lot of. I had done my master's in public health. I was a little bit older when I went back to school, so I had debt already. So I knew I needed help with the loan. So I did National Health Service Corps, which basically I owed them 3 years of service in an area of their choosing. And so they try to find underserved areas, which, luckily, unluckily, New York City counts.
All of New York City, or just parts of New York
Areas,
City?
yeah, parts.
Okay.
So I ended up in Hunts Point in the Bronx at a clinic, at a government clinic, federally qualified health center there. And did my time there. But it's a very strict program. So, right, like you take a day off or you have like scheduled closure days for clinic and they like
Yep.
tack that on at the end of your thing, right? So like we have a snow day and then all of a sudden you owe like an extra day. So
God.
So, and I took maternity leave. So basically my 3 years turned into
wow.
4 years.
Uh-huh.
And by the time that finished, I was like, I'm not going back into fellowship.
Yeah, 100%. That's something that people don't really understand either is so you did 4 years of undergrad. How long was your master's?
So I did 4 years of undergrad and then I did a 2 years, a master's in public health at Mount Sinai. And then
Okay.
I worked.
And then medical school after that.
Yeah.
Like you went right.
No, I took time. So I guess it was like 5 years total difference from when I graduated undergrad.
Okay. All right. So then medical school happens, 4 years of medical school, and now the pediatric residency happens. This is something a lot of people don't understand as far as our training goes too, where it's not just medical school, it's undergrad and whatever other thing that we decide to do,
right?
Plus medical school, plus residency. And now all of a sudden you're 38 years old
exactly.
And you're like, I don't have a child or I'm not married right now. This
That's
sucks.
Exactly. Yes. Did you read the story of my life? That is what happened. So, by the time that finished, I was like, all right, I'm not going back. Plus, I think, COVID broke all of us a little bit.
Yeah.
And
I was saying, because you graduated residency, you finished residency
2020.
In 2020, so you were right.
So Good Sam had one of the hardest hit areas for COVID. Our PICU turned into adult COVID ICU. So I was a third year pediatric resident caring for all COVID ICU, vents and coding and things that I hadn't done since.
Trial by fire, for sure.
Yeah. So after that, I said, I need to just live.
Be in a clinic with kids somewhere and not in the ICU anymore. But that's understandable.
I did that for a couple of years and then I said, I need to not do that again. I need to get back in a hospital. It's always got to be something. So so now I'm back working as a hospitalist, which interestingly, as in pediatrics, that is now also a fellowship. Yeah.
When did that happen? That's new for me.
In the last couple of years, they now have like hospitalist fellowships, which is another fellowship out after you do.
So do hospitals require the fellowship in order to hire you? Because it's still so new?
It depends. Yeah. So it depends. I'm not fellowship trained as a hospitalist. I worked hospitalist per diem the last 4 years that I was also in the clinic. And then I transitioned to full-time hospitalist after that. Some places now are starting to require it. Some places grandfather people in. I
would imagine the places that would require it are more your specialized pediatric hospitals as opposed to your general community hospital with like a pediatric floor or something.
Yep, exactly. And that's kind of where I am. I'm in a big system, but a smaller, more community style with a pediatric floor. We do not have an ICU.
Okay.
So anything that needs pediatric ICU level care is going to get transferred out.
Yeah, they do that.
We're working on growing our pediatric ER, but it's really, we have a general ER and most of the week we're staffed with PEM doctors.
Okay.
But not 20.
Yeah, I say in the non 24/7, you're getting guys like me in there who wake you up at 3 o'clock in the morning to say, hey, can you just take a look at this kid? Can I send him home? Yeah. I get that.
Exactly what that is. And I get it. And kids, the main thing of pediatrics that everybody says is like, kids are not just small adults, and they're not, right?
Yes.
So there are things about them that are going to be different. They scare people, right? Especially when you start having your own children and you start thinking like,
it's funny though. When I had my first child, I realized how much more comfortable I became around pediatric patients.
Yeah.
Pediatrics was not a major focus of my residency. We had a pediatric ER. It was more of an urgent care styled ER than it was a true high acute, high volume critical care type of ER.
Right.
So we saw a lot of the common stuff. We saw a lot of the colds and the allergies and things of that nature, but we never really received training on things specifically related to like small little babies. Okay, let's call them small little babies, tiny peanuts. Yeah. We'll call them peanuts, right? So I have my own peanut, and there's little things that they do that you're just like, is this normal?
Yeah.
Should they be doing this? They're breathing.
Wrong.
That's a little bit weird.
Seems wrong.
And so, but parents would come in because we have a pediatric ER. We staff it overnight. And the parents that come, bring them in, all different demographics, they bring in their 3-week-old, their 2-month-old, and they say, hey, they did this. Is this okay? And I'm like, sure. For me, it's like, well, they're breathing right now.
Yeah.
They're feeding okay. They don't look dehydrated, and now they're sleeping. I'm sure it's fine. Meanwhile, I'm thinking to myself, I don't know. First of all, I don't know how what are you describing right now? What is this?
Yeah. So that's a tough thing about kids is a lot of the stuff we do in pediatrics is like, let's just wait and see what happens, right?
Yes.
Let's wait and
Yes.
see if things get worse. Let's wait and see if they do it again, right? And like as a parent, that is terrifying, right?
It
you're
is.
Like, what do you mean?
It
We're
is.
just gonna like wait and see if it happens again.
And not for nothing, we also as physicians understand, especially in kids, we have a mantra in emergency medicine, kids are fine until they're not, which means they look good, and then all of a sudden they tank. Adults, It's more of a gradual decline. You're like, yeah, they're not looking too good. And you try to kind of catch them as they are, circling the drain, as we call it, right? But then kids will be like, they'll persist, all of a sudden they'll just, whoosh, and you're like, what happened? What did I just do? The parents who have kids, obviously, they don't know that, but they're also, it's their child too. They're worried.
Yeah.
And they're coming to you for advice. At the same time, you're like, well, it's also the emergency department. I'm trained in emergencies, life-threatening emergencies. What you're describing doesn't really sound like one, but it's also difficult to figure out what are you describing too. So the parents sometimes bring video, which helps. But at the same time, it's also such a quick little snippet that you're like, yeah, I can see why you're concerned.
Right.
But I don't think it's a concern right now. And that's the disconnect that the parents sometimes don't like.
Definitely. And, I think I had mentioned this before that we go off vibes a lot in peds where it's just kind of like, I don't know what that is, but it's not feeling bad. So we're just going to watch it, because like we don't like to do unnecessary things to kids. We don't like to poke them and hurt them and do things that we don't have to. And so a lot of times we're waiting just to see if something changes and then we have to do the thing,
So one of our bread and butter complaints, especially this past season, was vomiting. Parents brought their children in that, they vomited 2 hours ago. Or, they've been vomiting for the past 12 hours. And in an adult, my instinct would be, you've been vomiting for 12 hours. All right, let's get an IV line. Let's give you some fluids. Let's check some blood work, give you some medication, and we'll get you feeling a bit better. In kids, for me, it's, all right, depending on their age, I'll say, here's some Zofran, some anti-nausea medication, and I'll step back and I'll say, okay, let's give it 30 minutes to an hour, try feeding them again. Or we'll do a viral swab in the meantime. And then parents are like, that's it?
Right.
Like, yeah, that's it.
That's
what do you want me to do? Do you want me to poke your child? Do you want me to take this little needle and stick it into their vein? I can.
Yeah. And there's all these tests and we can do all this torture and it could tell us, okay, your kid has a virus and we're still not going to do anything, So like
it can tell us what we already know.
Right.
And that's, I think, the key thing there, that parents, we see so many kids, and like you said, you run off of vibes, but you run off of vibes because your training is such that you see these cases ad nauseum, you develop a pattern of recognition.
Absolutely.
So you develop these vibes that says, your child looks well. I'm not worried. It's likely this. Are we going to have the exact viral definition of what they have? Probably not.
Right.
But
and that's why I
fine.
never mind those 3 a.m. calls about, can you come take a look at this kid? Because chances are I'll be able to walk in and be like, yes or no, And if I don't, then I'm like, okay, well, let's try this. And it's only because that in pediatrics, that's what we're doing, right? Like you're seeing it enough times. And like you said before, the way a sick kid looks is bad.
There's obviously objective markers for how sick a child is, how they look. Can you talk about that? Like when you walk into a room, what do you look at? What signs do you look at that tells you, yeah, this child is sick. This child needs, blood work, a lumbar puncture, scan, whatever.
Yeah. So, obviously the other thing with pediatrics is that you're going from birth to 21. So I'm going to be looking for something very different on that. In general, if I come in and I see a 4-week-old and they're sleeping, I'm not stressed, right? They can sleep in an ER that's very loud because they're 4 weeks old, right? So like, that's not stressing me out. if I see a toddler who, just got labs drawn and an IV, and I walk in and like they're not moving and they're just laying there like I call it, like a wet noodle, like that, I'm automatically, why are you like that? Why aren't you fighting?
Like this? Why are you
why
not
aren't
moving?
you mad?
Move, do something, please.
Be mad. Yell at me, right? If a toddler is letting me check their ears and their mouth, like their throat, no problem, I'm more concerned, right? If I'm trying to check their ear and they're like hulking me, okay, this is good, right?
If they turn into Mike Tyson or Stone Cold Steve Austin, just elbowing you in the face. Exactly.
Yeah. And no matter what, if a parent brings a kid in and they're going to say they've eaten nothing all day, right? And I'm going to walk in the room and they're halfway through a bag of Takis, right? But they ate nothing, right? It's always going to be kind of biased what the parent thinks, right? Because they say, okay, well, they normally eat 5 bags of Takis and today they ate 1, so that's nothing. But those are kind of the things that I'm looking for. Are they appropriately afraid of me, if that is age appropriate? Are they fighting me back? Do they wake up when I examine them? One of the words that I'm sure, the pediatricians in your life have said that we really hate that parents use is lethargic.
Lethargic. Harry Child's lethargic. I've learned that he just seems so lethargic. Like, no, you did not just use that word.
No. And in my training, if you're telling me that someone is lethargic, then where's the code card? What am I doing? Right? We're about to go down. Versus, somebody says they're lethargic, but they're fighting me when I'm looking in their ears, like different thing, right? Some kids are sleepy, or, as we're going to get into, some kids with fevers are just like mushy and blah, right? But if you bother them enough, they perk up, they get annoyed, they cry,
exactly.
Right?
Yeah. So you throw some water on them, they wake up, they scream at you. Great, we're okay. We don't need to do anything. I had a case not too long ago, and the patient was sick for a couple of days, and it was nausea, vomiting, no real diarrhea, but they were basically not eating anything or drinking anything all day long. And one word that I like to tell parents and even my residents is they look punky.
Yes, punky. Do they use that outside of pediatrics? It's not.
I don't think so. And because parents look at me like, wait, what did you just say? Punky? Like, is my kid a punk? Like, no. They don't look well. They don't look healthy, but they don't look toxic. They don't look ill. Yeah. They look like they're just blah. Yeah. I don't feel good. And
those are my like blah. I do this.
Exactly.
That's what they're like.
But lethargic is what I like. Somnolent a little bit. So because EMS comes in with patients who are intoxicated, inebriated, and they're like, oh, they're lethargic. Like, okay, I guess they'd be lethargic, but it's more like they're somnolent. I can go to them and say, hey, you in there? Hello. And they'll kind of like, okay. But they're more somnolent as opposed to lethargic. We were thinking they're like,
right. Yes.
That's going to be a good face capture too,
that was
at
nice.
some point. So you mentioned before, so pediatric fevers. Fevers in general, we talk about are obviously for adults. You get a 102 fever, you're on your ass. Yeah. Like, I don't care who you are, you're on your ass 102. One of the common complaints we get coming into the ER, especially in the evening hours, overnight hours, my child had a fever. My child had a fever an hour ago. I woke them up from their nap and they were really warm. And I checked their temperature, or they felt hot, whatever. They have a fever. Please help me. And they kind of, they give you the child.
Take this, yes.
Just take them. So first of all, the question is, when is a fever a problem? Is it a problem? I guess that's a two-part question.
So, this, again, probably one of the things, outpatient and inpatient, that we see just every single day, all day long. And I like to remind parents that the fever is the body's reaction to something happening, right? So we just are coming through a never-ending viral season, right?
Yes.
Your kid,
it was
forever. It's still
going.
About
30 days and 30 nights in the Bible. This was way worse than that for us. It's
still happening. So, you've got the sniffles, and now all of a sudden there's fever, right? And most parents, the biggest concern is the number, right? Which is pretty much never my concern, right? The only thing I really get concerned about is, one of my pet peeves is a parent, comes in, they had a 99 Fahrenheit, fever. And I'm like, no, so like in our world, like 100.4 Fahrenheit, 38 Celsius, anything below that. And they're like, well, they usually are. No, right? So
I know my child's body.
Yes,
that's
I know.
The main thing.
This is usually.
Look, I'm probably going to develop hate for that because it's a common refrain that we hear from adults.
Yeah.
I know my body. This is a fever.
You might feel bad.
Right. You You feel bad. I am not denying that.
Right.
Physiologically and clinically speaking, is it a fever? No.
Right.
Is your body elevating its temperature? Yes. Yeah. That's where we need to figure out, okay, why is it elevating its temperature above its normal set point?
Right.
Clinically, is it a fever? In our sense, no.
Right. And, the times when that matters is very tiny little babies, right? So the neonates, and that is important. So, these guidelines have changed, and I'm honestly expecting the way that the world and vaccine rights are right now that these may change again. But
don't worry, I already gave the political disclaimer a couple episodes ago, so it is what it is.
So I do expect that this might change. But from our standpoint, we don't like to do things and hurt little babies if we don't have to. But tiny little babies, specifically babies less than, 28 days old, babies that are not vaccinated, those kind of things, they are more at risk for serious bacterial infections. And so a fever is not just a fever when it's a tiny baby like that.
So
that a baby, that is 18 days old had a, rectal temp of 38.5.
101.6. Yeah.
Then it's like, okay, well then we're doing this, right? So that
and what
baby,
are we doing?
Yeah, what are we doing?
What are we doing to your baby?
We are
at
doing
18
the
days
things
that has a fever.
We don't like to do. So basically poking them in all the places. So they're getting labs, they're getting for blood cultures, they're getting urine, which is going to be a cath urine, and they're getting a lumbar puncture.
And a cath urine, that's when we stick the tube inside the urethra, wherever that is. And
get the pee. Yeah.
Yeah.
And then, the needle in the back of a very tiny baby.
There's a lumbar puncture. Yeah. So that's what I discuss with parents too, is listen, if you're coming in and you're telling me your neonate, your infant had a fever at home, a lot of times they don't actually check it. They don't have a rectal thermometer or any kind of thermometer. So they said, I checked them and they felt warm, and they come in and they're 20 days old. And I'm like, all right, we really need to investigate this here. We do an actual rectal temperature and it's normal.
Right.
And then the parents will still say, well, they still have fear. I'm like, listen, you're telling me that they have a fever, clinically a fever at 20 days old. That entails an IV line, blood work, antibiotics. I don't care that we don't have any results, but you're getting antibiotics, and a lumbar puncture where I stick a needle. Well, for needles, it's probably yay big, but for adults, it's
big in comparison.
It's yay big. Into your child's back to drain fluid. That's what, if you're telling me that they had a legitimate fever, this is what we're doing. And as I talk, their eyes start to widen more and more. Right. And they realize, oh, yeah, no, let's not do that.
Right. No, wait a second, let's think about it. Yeah, exactly. So, if we have to, we do those things. But that is the time when, the number is something that I'm really fixated on. So
to that end, what number scares you outside of the 30-day infant window, right?
Yeah, so just like a regular old kid.
A regular 6-year-old comes in.
Honestly, there's not a number. Right. Which sounds kind of crazy. But, in our training, we talk a lot about how some kids can tolerate really high fevers. And I know that our grandparents told us that your brain will cook itself, but it's not outside of something outside the body being wrong. Right. So heat stroke.
And
right.
That's important. Things. That's the key.
Yeah. That's something I like to bring up because it's, the kids who are left in cars, in hot cars, that can get their body temperature up past the point where there's nothing.
There's starting to be laws about that right now for that reason too.
Yes. And so that, or something, that other things that are physiologically happening outside of the body,
drugs.
Yes.
Let's be honest. There are parents out there who are bad parents, and objectively bad parents, not the people who feel they're bad parents. Objectively bad parents who leave things like amphetamines, and their kid gets into it, and all of a sudden now their temperature is legitimately 108.
Yes. Right.
And
so that's different.
I tell people, your body has a set thermometer. Your body will not rise above that set thermometer by itself. It has to have external forces. So yes, your child has a 104.5 degree fever, and I look at the kid and they're running around making a mess of things. I have a 104.5 degree fever. I'm on my ass, literally on my ass.
Yeah, no, that's the
not
end.
Moving. Don't talk to me. Okay.
Yeah. And so there's not a specific number, again, it's going to be more about how does the kid look and why do we think that this is happening? Right. I think the fear for parents is this like I said, they think the brain's going to get cooked, but also the real fear of febrile seizures, that parents have heard about. And then
Mm-hmm.
that's the thing in their brain that if they
Yes.
get to this number, there's going to be a febrile seizure, and that's
That is a
not,
very
yeah.
common, yes, and that's a very common reason for why we see kids in the ER as well, is they had a seizure. And we always want to say, well, was it a febrile seizure? And most of the time it was. We checked
Yeah.
their temperature, it's
Yeah.
elevated. So, two questions really
Mhm.
stemming from this. First of all, how long does a child have, let me rephrase, how long are you okay for a child to have a fever? At what point do you get concerned that, hey, my child has had a fever now for 2 days, 3 days, 7 days? What's
Yeah.
going on?
So this is a really good question because for my training in the pre-COVID era, 5 days was our kind of threshold because then we started thinking about things like Kawasaki disease and so in our head it was
That's going to be
kind
a
of,
whole other topic.
yeah, no.
You just named the motorcycle.
You'll have me come
Okay,
back.
we
Yeah,
got
yeah.
to talk about that later.
Yes, you'll bring me back for that. But so 5 days was like this number in our head, right? But in a post-COVID world where some of these viruses now that we're seeing, especially at kids who were in quarantine for a while, and now all of a sudden they went to kindergarten for the first time or whatever, and they're getting viruses and they're having fever 5, 6, 7 days, but they look okay. They look good. They're
Yes.
happy and they're doing whatever their thing, but then randomly they'll spike a fever, right? So if that's happening, if you're at 4 or 5 days, I mean, you definitely need to be seen by your doctor. And you definitely need to have some kind of exploration for why it's happening, right? But 2 days and you're eating and you're drinking, I'm not stressed about it. 3 days, you're eating and you're drinking, fine.
So let's say parent brings their child to the ER, 5 days of fever, no symptoms. They're not coughing. There's no runny noses. You check
Hate
their
that.
ears. There's nothing there. There's no vomiting. Now what? Like, am I legitimate? Is the parents, they come to the ER, the parents are saying, my child's had a fever for 5 days, objective fever, not 99.1, but
Right.
101.5,
yeah.
gets better with Tylenol.
Mhm.
And now what? Should
Yeah.
they expect that we're going to do blood work or lumbar puncture?
Yeah, so I mean, that obviously is going to be kind of a clinical call for each doc, but the fever on its own is not the thing, right? In a healthy, well-appearing kid. And so common things being common, they've got a weird virus that's just not showing the sniffles, right?
Mm-hmm.
Like kids are exposed to everything in their daily lives, and
Oh yeah.
Sometimes
Everything goes in the mouth, everything
Yeah.
goes up the nose, the ears,
Gross.
whatever.
And a lot of times they're doing it like they've got 2 viruses happen at once, or they just had one and now they got another one, like piggyback. So those kind of things are the most common reason that this is happening, right? So in a
There's a joke I
well-appearing
like to
kid,
make. Yeah, there's a joke I like to make called Hickham's dictum. The patient can have as many diseases as they want.
Mhm.
It's not like, hey, you got the flu. All right, well, sorry, COVID, sorry, rhinovirus.
Right.
We're full right now. We can't admit you. They're going to come in anyway,
Yeah.
and they're going to come in the middle, the end, doesn't matter. And that's what a lot of parents who send their kids to daycare realize for the first timers, like, my child's always sick. It's like, yeah, they have a virus.
Yes. Yeah.
They just had a virus.
The whole time.
Also true. That's also a thing.
Yes, my daughter's going to be 4. She's probably had a runny nose since she started daycare at 6 weeks. So it's, like
it's just been constant. It just keeps going.
It's just that's how she is now. That's just who she is. It's not necessarily the timing. Like, obviously, if there's prolonged fevers, we're going to start to look around for a reason for it a little more. But again, it's not something that is, oh my gosh, panic, and we're going to go do all the things, and it's automatically the worst thing because the most common thing is going to be some virus.
Yeah. And like you said, common things being common, that's what we say in medicine a lot. At the end of the day, we're looking at more common things. We're not looking at the uncommon. And there are certainly uncommon things out there that children are going to have that are going to be missed.
Yeah.
Not for nothing. We are going to miss that the first or couple visits until the routine testing has already been done. And your doctor is not an idiot for missing that.
Right.
It's just we have to look at common things first before we look at the zeros, I say.
Right. Otherwise, every
mentioned
kid's getting a needle in their back and nobody wants that.
Yes. Now, you mentioned the guidelines. What guidelines are you talking about as far as fever goes?
So, there's AAP, American Academy of Pediatrics, comes out with the guide. A lot of the hospitals that we have are following like CHOP, Children's Hospital of Philadelphia guidelines. In Peds, we're real big on algorithms and stuff like that of, trying to standardize these things for the kids so that we're not doing the unnecessary testing.
And that's the key, is unnecessary testing. At the end of
Yeah.
the day, we likely know what's going on, but we want to minimize your kid getting poked and prodded. So these are protocols that everybody follows, not just pediatricians, but emergency medicine, hospitals, whatever.
Right. There's a lot of work that goes into them and a lot of, research, which is like, I feel like a trigger word these days, but
Yep.
there's a lot of that is
Hmm.
happening behind the scenes to sort of adjust where at some point it was every kid under 2 months old is getting this full workup. And then it's every kid under, 40 days. And then it's every kid under 30. And now we're at 28. Right. And there's all these kind of levels of it, which is great. Right. Because it means we're getting better and better at kind of narrowing down the kids who absolutely have to do all the tests, right?
Yes.
And we're able to do that because we are kind of doing this research and finding out how often are we missing something if we don't do a lumbar puncture in a 5-year-old with a fever, right? And
Yes.
we found we're really not missing that much, right? There's usually something else, right? There's something else that they're showing us that causes us to want to go down that path. And it's not the fever itself.
Yeah, and the source of the fever is what our main concern is. Fever is a symptom. If we suspect a source to be just a virus because everybody in your family had a fever and has the same virus,
Yes.
it's fine.
Yeah.
But, like you said, neonates especially, they're immune compromised from the get-go, and that's when we need to start looking at, really look at what's going on. We give Motrin and Tylenol to make the child feel better. Does that mean I need to give my child Motrin and Tylenol around the clock?
Yeah, good question, because that is something that we used to do, right? Especially, if we had kids with febrile seizures and then we were sending them home, we were like, okay, give Tylenol, Motrin. And again, research, so important, has been coming out showing that this doesn't really change the risk of them having another febrile seizure, right? It does help to keep them comfortable. There is some data about that it can be confusing for parents. Like, which did I just give? Did I give Tylenol? Did I give Motrin? Should I just stick to one, right?
Risk of overdose.
Right. I'm always going to hear, the parents say, well, this works better for them or this one works better for them. So in general, my recommendation is like, if the kid looks like if they're looking a little punky, they're like not feeling really great, you can give them Tylenol or ibuprofen, right? Correctly dosed to make them feel better.
And we dose it by weight. So that's the other thing too. As a father, you get the Tylenol and the Motrin, and it says, children under 2, please consult your doctor. Yeah. Oh, great.
Now what? Yeah.
Now what?
Yes.
But now I obviously, we both understand, okay, it's weight-based dosing. My child weighed this at their last checkup. I can at least give them this. And
exactly.
That's something that parents should know as well. And ideally, that's where the calls to the pediatric office come in. Like, hey, my child has Motrin. Hopefully, somebody in the office or clinic or whoever can say, your child weighed this at their last visit. Yes. It's okay to give them
this much,
5 mLs or this syringe full, you know?
Exactly. And again, it's, this is not curing anything. It is making them feel better. It is usually making parents feel better, right? But it's not fixing anything.
And we often get parents who come in and say, I gave my child Motrin, the fever went down, and now it's back again. Right. Now what? And the answer is it's going to come back until whatever stimulus, whatever infection is causing this fever, your fever will be there until your body reaches a point where it's beaten down that infection enough that it doesn't need to spike that fever. Here's a question for you. I don't know if you know the answer to this. Are we over-treating fever? Should we let fevers run?
Yeah, so I think we probably do, because there is not a reason in a kid who's not feeling bad to necessarily be giving it around the clock, right? So I do think that parents obviously don't want to see their kids being miserable. Mm-hmm. They also get scared when their kids are sick, right? And this is like a relatively benign thing in their mind that they can give to help make it better, right? And it's something they usually have in the house. They don't have to go see their doctor, right? I don't necessarily care if you took the temperature. So especially in a kid that we know has something like a fever. Let's say you got something like a virus. You have a kid who's 5 years old, cough, runny nose, they're fine, but they've got a fever. We assume it's whatever virus, doesn't matter.
The virus of the week, as
the
I
virus
say.
that they have. And so I don't need to know that they were 101 or 102. Like, it doesn't matter. If you feel them and they feel hot, cool, fine. If you want to give the Tylenol and like you didn't just give it before and you have it and it's appropriate, fine. You know, are we overtreating it? Yes, probably.
There has to be something somewhere along the lines that, all right, our body's raising its temperature for some evolutionary advantage to warm it enough to kill whatever virus is in there. And I've seen some YouTube videos and articles regarding it, and they say, well, treating the fever may prolong the illness time.
Yeah.
It may prolong the illness time. And that is because your body is mounting some defense. It's a defense mechanism against an insult that, evolutionary speaking, has benefited us in the past. So why are we preventing that from doing its job?
Yeah.
And the argument makes sense to me. And that's kind of what I say to parents too, in a way that I say, look, it's up to you if you want to treat the fever. I'm not telling you to treat the fever. You're not preventing anything bad one way or the other here.
And with my own kids, if my kid has a fever and I know they have a fever because my daughter got ear infections all the time when she was super little. So I know she had an ear infection. I know she has a fever because of the ear infection. Doesn't seem to bother her at all. She's running around being a crazy kid. I'm not going to treat it. Right? If she is like crying,
you're a bad mother.
I know, exactly. If
bad
she's
mother
like
and a bad pediatrician.
When she's curled up on the couch and she just looks so sad, I'm like, oh, you need some Tylenol. But again, we're going off vibes here. This is not science-based. This is just kid feels bad, and when kid feels bad, mom gets sad, and so I'm giving you Tylenol, right?
I like that. When kids feel bad, mom gets sad.
Yeah. So it's, but again, I probably give less Tylenol to my kids with their fevers than a non-pediatrician parent because it just doesn't worry me as much.
And I think there's a lot of parent shaming out there on social media, especially in the last several years. So I think it's also important to say that if you want to give your child medication, do it safely, do it under the consultation with a doctor, and that's fine. If you don't, you're not causing them harm either.
Right.
So it's whatever you feel is best for your child. And if you have questions, people like you are always here, and me are always here too.
Right. And I feel like a lot of things, there are cultural and generational things that people believe work for fevers or colds or coughs. And most of the time, I don't care. If you want to put, Vicks on the bottom of their feet before bed, that's totally fine. I don't know if it's going to help.
What age for the Vicks?
So that's a good question. Usually I don't have anybody do it under 2, just because 2 is like an age for me. But they probably say 1 or something on the jar.
Does it actually say on the bottle?
Yes.
I wasn't
sure.
I don't,
if it's on the feet, it's different, right? So like when, in where they're breathing it in, I don't almost never recommend it, just because some kids can like easily be triggered in like coughing
allergies or whatnot.
Yeah, exactly. But again, in an older kid, that's not going to worry me so much. If they want to do like, a cool bath, again, that's fine. If you want to do it, don't put your kid in an ice bath, right? It's not going to make it better. It's mean. I'm like, if you want to do a cool bath, fine. Also probably not going to make it better, but not harmful, right?
They may liven up too. The water, they're splashing around the water to have a little bit of fun.
Exactly. There isn't always a scientific answer for some of these things, which makes us as like scientists very uncomfortable. But in general, if I can like be assured that it's not dangerous, then,
yeah, at the very least, we're scientists, but our first part of our oath is do no harm. Right. So as long as it's not causing harm, then that's fine. Yep. Do what you feel like you want to do.
Right. And if you're telling me it made your kid better, awesome. I'm glad that your kid's doing better.
One final question before we go here. Is there a temperature where you consider antibiotics?
Good question. No. I mean, again, outside of the neonate, never trust
the pathway.
Neonate.
Yeah, if we're going just by vibes.
Yeah, by vibes.
If we're just like, hey, my child, there is not.
There is not a number.
Has that been shown by research, or is that more just...
Oh, so that's a good question also. So things that, because if it had been shown by research, then it would be on these like serious bacterial infection pathways, but there's really not a great correlation to it on fever alone, right? Like, we have correlation to it with all the other things, right? Inflammatory markers, that kind of stuff. But like, But
Yeah, when we're going down the blood work route, we're checking these markers that we check on the blood work are going to guide us about antibiotic usage or not. So if your child's sick enough that we're getting blood work, there's
then it
a
starts
non-zero chance you're getting antibiotics. But beyond that, just because you have a 104.6 or 106 fever,
but your kid is
doesn't
great
mean
and
you need
they're
it.
eating, drinking, and they're like, playing, then it doesn't mean like ear infections can give super high fevers. They're going to get antibiotics. Viruses can give super high fevers. They're not going to get antibiotics, right?
Yes. Good. All right. Well, thank you, Dr. Maggie Gaughran, for coming on, discussing pediatric fevers, clinical pathways, all sorts of things, and most importantly, vibes. I think that's just one takeaway from this episode. It's we go on vibes, ladies and gentlemen. Maggie, I'd love to have you back on here. There's a lot more in the pediatric world to discuss. If you think of an idea, if our viewers, listeners have any ideas for future, if they want clarification, please feel free to reach out, especially.
Yes.
So, but Maggie, thank you so much.
Thank you. Glad to be here.
All right. Well, that wraps up another episode of the JAFERD Cast. Thanks again to Dr. Maggie Gaughran, pediatrician, joining me this week to talk about pediatric fevers. If you enjoyed this episode, please don't forget to like and subscribe and turn on notifications. We are on YouTube and Spotify with more platforms to hopefully come in the future. I love constructive feedback, and ultimately, this show is to help you, the listener or viewer, make informed choices with regards to your own health and to help raise awareness about the issues facing healthcare at large. You can leave your thoughts in the comments below for those who are on YouTube, or email them to me at jafferedcast@gmail.com. If you're in the healthcare field and you're interested in being on the show to discuss topics in healthcare, please feel free to reach out as well. Or if there are topics that you want to hear more about, please email them to me. I'm always open for suggestions. As with anything though, don't take my word for it. Do your own research, talk to your own doctor, and remember, at the end of the day, I'm just another fucking ER doctor. Make good choices, everybody. We'll see you next time.